Sorry, the interventional perspective. I'm sorry.
Yes. Most important is. All right. Assalamu alaikum. Thank you for the organizing committee and scientific committee for the invitation. It's always a pleasure and honor to be here with the JS. So I'm going to talk about VSD post-MI from intervention perspective. So facts about VSR is incidence 2 per 1,000 in current PCI area. The prognosis is very poor if treated medically, 50% mortality at 1 week and 90% at 2 months. VSR usually leads to severe left to right shunting with severe hypertension and LV volume overload. 50% of patients with VSR will develop cardiogenic shock and 20% will usually associate with other mechanical complications. Diagnosis usually having pansystolic murmur, 90% with a thrill in 50%, and you do the usual transthoracic, TE, LV-gram, right heart cath, CTA, and MRI. Now, this is from basically the previous or the literature showing the risk factor, usually female, old, first presentation of anterior MI hypertension. There are also some protective factors, having chronic angina, diabetes, and previous MI, and this is because of preconditioning, ischemic preconditioning and formation of collaterals. Those patients protect against having rupture. Now, the VSR could be classified basically, and this classification was adopted from HIPAA, basically pathologists, but it's very important clinical and basically surgical consequences because it could be classified in simple or complex. The simple, basically, they usually direct through and through opening, no hematoma, no laceration or dissection in the wall, and the openings on both sides usually in the same level at the intraventricular septum. However, when you look to the complex, usually multiple opening, cerviginous cords, hematoma, laceration, and the opening usually in different plane, which might affect basically any intervention, either surgically or transcatheter. Now, if you're going to classify the according to the location, it could be classified according as apical and basal, basically ventricular rupture. Usually the apical results from middle AD occlusion, acute occlusion, and basal usually results from PDA occlusion, whether from RCA or usually from the circ. Now, apical usually associated relatively with good prognosis. Only 20% of patients with apical, usually VSD, they will have basically complex VSR, while the majority of patients with basal VSR, usually they will have complex VSR. Now, basal VSR in comparison to apical usually associated with RV infarction, anatomical complexity, and other rupture in some areas. The LV usually RV function depends on the location of VSR. When you do the anterior location, usually the LV affected, and usually not in the poor LV function, just in the mild to moderate, the range of 40% as in this study. While when you deal with basal, usually inferior location, RV involved more than LV. Cardiac CT is very useful, basically to diagnose, to localize, and to help in the treatment, whether treatment will be transcatheter or surgically. Now, this is basically the scheme published recently in the JACC regarding the best approach to those patients. Very important early hemodynamic profiling and risk classification to classify patients in stable or unstable. Then heart team meeting evaluation. Then basically decision will go to surgery, transcatheter, depends on the patients, whether they have multiple disease or their comorbidities. However, transplant or palliative care might be considered in the extreme of both sides. Now, when we talk about initial treatment, usually airway hemodynamic monitoring using pulmonary artery catheterization is recommended. Vasodilator. The question of having coronary vascularization is always a debate in those patients, whether to basically revascularize or do primary PCI to those patients. In area supplying VSR with already completed infarction, having to do PCI for non-culprit lesion in patient presented with VSR will be also a debate in this situation. Addition of dual antiplatelet therapy prior to open heart surgery increase the risk of bleeding for those patients. Now, another important thing, you have to be always consider using mechanical circulatory support as a bridge to definitive therapy in those patients. Looking at this study from China, basically it's a single multi-center study in around 35 patients. We look at the timing of PCI when the patient presented with a VSR. There is around 25% they have actually the PCI before the VSR closure, simultaneously done in around 5.7%. And in the majority, 68%, they have the VSR closure before actually the PCI. Now, Looking at the success rate of having this approach when the patient presented with acute MI VSR, the device success rate was around 92%, and the procedure success was around 91%. And looking at the death during hospitalization was around only 15%, and during follow-up, actually up to 53 months, there's still the mortality, only 2 patients out of 35 actually they had passed away. Now going back to which mechanical circulatory support has to be used in this patient basically, and the recommendations, they give clear class 1 indication to use intra-aortic balloon pump in the context of any mechanical complications. Considering that how intra-aortic balloon pump will affect basically the flow across the VSD, the PA, and the pulmonary to systemic flow ratio, and even in the aortic pressure and pulmonary capillary wedge pressure. However, Impella has very, very important role, and there is seem to be safe and effective in patients actually, in multiple small study in patients who has VSR and the cardiogenic shock. Now looking at the ECMO, considering the ECMO will increase the flow across the VSD and increase the pressure, the pulmonary artery flow, and actually decrease the ratio of pulmonary systolic pressure, as well as increase the pulmonary capillary wedge pressure. It has probably a deleterious effect. This is hypothesized based on this study. So ECMO might be not considered, at least for patients who could be managed with Impella or intra-aortic balloon pump. Now, the choose, I think, between both has to be the many factors, whether this is favorable for a percutaneous approach or surgical approach. And this situation depends on whether you deal with a single, simple defect, and defect size is 1024, or patient who has basically sufficient SREMs, adequate distance from valve apparatus or previous unsuccessful surgical attempt. If that in the case, then probably the patient will go for surgery, depending on the situation. We know from previously, basically, the STS score that the mortality in a patient who presented with cardiogenic shock and VSR is reached up to, if they require VSR and CABG, up to 58%. So why we need transcatheter closure of VSR? Basically, because the patient will have triple insult from having left to right shunt, weakening infarcted myocardium, as well as open heart surgery. Early surgical repair associated with significant high morbidity rate. Transcatheter closure seem alternative option in patient deemed to be high risk. Most of the patients with VSR, they are already high risk. Transcatheter closure techniques has associated with high success rate, and transcatheter closure can be used in a patient with residual risk after VSR repair in a state of having basically redo surgery. Now we have nowadays a very actually dedicated device to do what's called Amplacer post-infarctal muscular device. It's 10 millimeter longer waist that can accommodate basically the thicker septum of adult. Now when we talk generally about approach, also we have 3 major approach going retrograde through the aorta all the way to the pulmonary artery, then basically snare and externalize the artery, then do the procedure usually through the right IJ or right femoral. We have also, we can go through antegrade transeptal by having transeptal puncture, then through that basically do the same through externalization and snaring and externalization, then basically through the right IJ. We have also hybrid approach with a small surgical incision. So I'm going to quickly in a case, 76-year-old female presented with acute MI, late presentation. She came in cardiogenic shock. We diagnosed her to have apical VSR. Then coronary angiogram showed basically patent stent in the RCA. You could appreciate the LED is occluded in the mid-segment.
Your time is almost up, Dr.
Yeah,
Abdullah. If you just go to conclusion, please.
So I'm just going to show you the final results we did for hair closure with transcatheter approach with excellent result. Okay, so I think take-home message, VSR continue to be a challenging complication of MI with poor prognosis, despite the effort to improve outcome, numerous surgical repair techniques, literature.
Right.
Almost 15 seconds.